Okay, let's dive into something specific today. We've got a set of detailed revision notes focused entirely on one condition, esophageal candidiasis.
That's right. Think of these notes as a really focused source document. Our mission here is, well, to take all that structured information, the definitions, causes, risks, all of it, and sort of unpack it, distill it down. We want
Yeah.
to pull out the absolute most important, high-yield knowledge you need about this condition, turning those notes into a clear, easy-to-digest deep dive.
Exactly. It's like a shortcut for you, whether you're revising for an exam or maybe just need to get up to speed fast on this particular topic.
Yeah.
We're going to cover all the key aspects laid out in the notes, building our understanding step by step, from what it is to how you treat it and what can go wrong.
We'll follow the path these notes set out.
Mm.
Definition, causes, who's at risk, how it happens, what else it might be mistaken for.
Right.
Who typically gets it, the signs and symptoms, how to figure it out, how to manage it, the prognosis, and, the potential complications.
Let's jump right in with the basics then. What exactly is esophageal candidiasis?
Okay, so at its core, it's a fungal infection affecting the esophagus. It's caused by an overgrowth of Candida species, and the notes are very clear. The main culprit here is Candida albicans.
Okay, so fungus. But isn't Candida something that's, well, often already present in the body? How does it turn into an infection in the esophagus?
That's the key point, really. Candida is often part of our normal flora,
Mhm.
living harmlessly in the gut, mouth, elsewhere. What the notes absolutely emphasize is this crucial association. Esophageal candidiasis is powerfully linked to a weakened immune system.
Ah, okay, so the immune system usually keeps it in check, right?
Precisely. When the immune system is compromised, Candida,
Yeah.
well, it sees an opportunity.
Right.
It seizes the opportunity to overgrow and become invasive. The notes give examples of conditions that cause this: HIV/AIDS, people undergoing chemotherapy, organ transplant recipients, and individuals with conditions like diabetes.
The notes also have a brief mention about diagnosing oral candidiasis, oral thrush, talks about swabs and culture, and specifically says serology isn't useful because Candida is so common. And it links this to suspected drug resistance in HIV-positive patients. Why bring that up here?
That's a good point to connect. Oral and esophageal candidiasis often occur together, especially in people with weakened immunity. So seeing oral thrush is kind of a visual clue that might prompt you to look further, for esophageal involvement.
Okay.
And the note about serology, that's more point about diagnosing Candida infections. Just finding antibodies isn't enough when the organism is,
Right.
everywhere.
Too common.
Yeah. And linking drug resistance to HIV patients. That just circles back to that core theme of compromised immunity and the challenges in treating these infections in, vulnerable populations.
That makes sense. If you see it in the mouth in someone at risk, definitely think about checking the gullet. So let's move from the what to the why. Etiology, the causes. We know Candida is the main cause, specifically C. albicans, but how much variation is there?
Well, while C. albicans is responsible for the majority, the notes do highlight that over 15 Candida species can cause candidiasis.
15. Wow.
Yeah, but the notes list the most common culprits beyond albicans, which together make up about 90% of cases. Candida glabrata, tropicalis, parapsilosis, and cruce.
Okay, so that's still a significant chunk covered by just a few main ones. Is there anything particularly sort of tricky or notable among the others?
What's really jumped into the spotlight recently, and it is mentioned in the notes, is Candida auris.
Oris, right? Yeah.
It's a newly identified species, and the critical point about it is its frequent resistance to fluconazole, which is often the go-to treatment.
Oh, right. That's a problem.
It is. The notes mention finding it on the skin, in the urogenital tract, the respiratory tract.
Wow. So you can't just assume any Candida infection will respond to the standard stuff. That adds a layer of complexity, doesn't it?
Absolutely. It really underscores the importance of knowing which species you're dealing with, especially if treatment isn't working as expected.
Okay, so we know what it is and the main players involved. Who is most likely to get it? Let's really dig into the risk factors. We've already mentioned weakened immunity is central.
Right. The primary risk factors highlighted are exactly those immunocompromised states: HIV/AIDS, chemotherapy, organ transplantation, anyone on immunosuppressive meds. Diabetes mellitus is also listed as a major factor.
But the notes have this much longer list too, right? What else makes someone vulnerable?
Yes, that additional risk factors section really shows just how many things can tip the balance. It includes the use of antibiotics or corticosteroids. These can disrupt the normal balance of microbes.
Giving Candida a chance.
Exactly, giving it a chance to flourish.
Antibiotics seem a bit counterintuitive for a fungal infection, though. Why is that a risk?
Great question. So antibiotics kill bacteria, right? Including the good bacteria that normally compete with Candida for resources and, space.
Ah, okay. Less competition.
Precisely. When those bacteria are gone, Candida faces less competition and can overgrow. Corticosteroids, on the other hand, suppress the immune system more directly.
Okay, that makes sense. What else is on this long list? It seems extensive.
It is. It includes things like invasive esophageal procedures, poor oral hygiene, malnutrition, broad-spectrum antibiotics, again, that link central venous catheters, parenteral nutrition, so feeding lines.
Central lines and feeding, how do those increase risk?
Well, they could be direct routes for infections sometimes, or they often represent a patient who is already quite ill and likely has some degree of immune compromise anyway.
Right.
The list continues with conditions like Cushing's disease, renal replacement therapy, implanted prostheses, radiotherapy involving the esophagus.
It even mentions pregnancy, high estrogen pills, iron deficiency, certain skin diseases like psoriasis, general weakness or debility from, say, cancer, and even the extremes of age, very young infants and the elderly.
It's a surprisingly broad range, isn't it? But when you step back, most of these factors either, compromise the immune system, or they create a break in the skin or mucosal barrier, maybe disrupt the local environment where Candida lives, or they just involve underlying illness that weakens the body overall.
Yeah.
Recognizing this wide spectrum is really important for thinking broadly about who might be at risk.
That extensive list really brings home how systemic or even seemingly localized issues can create the right environment for this fungus. So we understand the risk. How does the infection actually, set up shop pathophysiology?
Yeah, okay. So the notes describe a pretty direct process. It starts with the overgrowth of Candida species, usually those already colonizing the GI tract.
The ones that are normally kept in check. Yeah.
Exactly. When the immune system or the local environment changes, because of those risk factors we just talked about, they multiply. The next step is invasion. The Candida organisms actually penetrate the esophageal mucosa, the lining of the tube.
And that's where the symptoms came from, the pain and stuff.
Yes. This invasion triggers inflammation, and that inflammation leads to the formation of the characteristic white plaques or patches that you might see on endoscopy. In more severe cases, the notes point out it can penetrate deeper layers of the esophageal wall, causing more significant tissue damage.
So it's not just sitting on the surface, it's actively invading the tissue itself.
Precisely. That's right.
Now, pain or difficulty swallowing, you see those symptoms in a lot of different conditions, right? So what else could it be? What are the main things on the differential diagnosis list?
This is a critical point for clinicians, definitely. If someone presents with symptoms suggestive of esophageal candidiasis, especially that pain on swallowing odynophagia, you absolutely have to consider other possibilities. Things that might cause similar symptoms or, look similar on examination.
Okay.
The notes list several key differential diagnoses.
Give us a list. What should we be thinking about?
Okay, so you've got gastroesophageal reflux disease, or GORD, very common.
Right. Heartburn.
Yeah. Then there are other infections affecting the esophagus, like herpes esophagitis and cytomegalovirus, or CMV esophagitis.
So other viruses can cause similar inflammation, especially in the same patient groups.
They can, yes, particularly in those immunocompromised individuals. The list also includes eosinophilic esophagitis, which is more of an allergic or inflammatory condition.
Okay.
Corrosive esophagitis, caused by ingesting caustic substances, and esophageal tumors.
Tumors could certainly cause swallowing problems. Makes sense.
Definitely. And then it's also mentioned certain other inflammatory conditions like eosinophilic gastroenteritis. The main takeaway here is that while classic symptoms in a high-risk patient are highly suggestive, you need to keep these other possibilities in mind, especially if the clinical picture isn't quite straightforward or maybe the treatment isn't working like you'd expect.
Okay. Switching gears slightly, let's talk epidemiology. Who gets this, thinking about broader populations? The notes mention the prevalence in the UK is actually unknown, which is interesting.
It is, yeah. It suggests it might not be routinely tracked in the general population like some other conditions, but despite that unknown figure, the notes strongly reinforce its prevalence in immunocompromised individuals. They really hammer home that association with HIV/AIDS again. Candidiasis overall is also noted as common in newborns and AIDS patients.
So it's particularly a concern in those vulnerable groups we've discussed multiple times now.
Exactly. And the notes add that Candida species are a common cause of invasive fungal infections seen in hospitals, which ties back to some of those hospital-associated risk factors, like central lines and prolonged illness.
Right.
Another important epidemiological trend noted is the increasing global prevalence of non-albicans Candida strains.
Which brings us back to the Candida auris point we mentioned earlier. The epidemiology is changing, and that matters clinically. Okay, so what does it actually feel like for someone who has this, the clinical presentation?
Well, primary symptoms are definitely related to swallowing. The notes list difficulty or pain while swallowing odynophagia as a really key symptom.
Okay.
That pain is often felt behind the breastbone, described as retrosternal chest pain, and sometimes it could be confused with like heartburn or acid reflux symptoms.
Any other general symptoms people might experience?
Yes, nausea, vomiting, weight loss, and loss of appetite are also noted. The notes specifically state that dysphagia, which is the difficulty swallowing part, and odynophagia, the pain, are common and often occur alongside oropharyngeal candidiasis, so oral thrush.
Right. So seeing that oral thrush and someone complaining of pain when swallowing is a pretty classic red flag, especially if they have those risk factors we talked about.
Absolutely. The notes also frequently associate this with treatment for blood or lymphatic cancers, again reinforcing that immune-compromised link. And this is a really significant point. In HIV-positive patients, esophageal candidiasis is actually considered an AIDS-defining illness.
Wow. So its presence means their HIV infection has progressed to AIDS.
That's right. It's a powerful marker of significant immune system decline.
Okay. Given those symptoms, how do you definitively figure out if someone has it? Investigations, what do the notes say?
According to the notes, the gold standard, the definitive way to diagnose esophageal candidiasis is endoscopy with esophageal biopsies.
Right. So putting a camera down.
Exactly. It is inserting a thin, flexible tube with a camera down the esophagus. This allows direct visualization of the lining, where you can often see those characteristic white plaques. And then biopsy samples are taken from these areas. They're sent for microscopic examination to actually see the Candida organisms, and also for fungal culture to identify the specific species involved.
That makes sense for a definitive diagnosis. But the notes also mention a more practical diagnostic approach, something about a therapeutic trial of fluconazole.
Yes, this is a common approach in clinical practice, especially in a patient with known risk factors, like advanced HIV or recent chemo, who presents with typical symptoms like odynophagia and maybe even oral thrush.
Okay.
The notes state that most patients with candidiasis will show a significant response to oral fluconazole within about, say, 7 days, if their symptoms rapidly improve.
It strongly suggests that's what it was.
Exactly. It's highly suggestive that esophageal candidiasis was indeed the cause.
So you can sometimes treat and see if they get better, and that helps confirm the diagnosis, even if endoscopy is the absolute definitive test.
That's the approach the notes outline, yeah. A positive response to the therapeutic trial is clinically very useful, but, endoscopy with biopsy provides that visual and pathological confirmation.
All right, once it's diagnosed or strongly suspected and you're initiating treatment, how is esophageal candidiasis managed? What's the plan?
Well, antifungal treatment is essential. The notes clearly state the first-line treatment is oral fluconazole. They give a dose range of 200-400 milligrams daily.
And what if fluconazole isn't working? Maybe because of resistance, like we discussed with Candida auris or other non-albican species?
Good point. The notes list the second-line treatment options. These include itraconazole oral solution, oral posaconazole, or intravenous or oral voriconazole.
So other antifungals.
Yes, alternative antifungal agents that can be used if fluconazole fails or maybe isn't appropriate for some reason. The notes also mention that hospital admission should be considered for severe cases.
Why is that?
Likely for intravenous antifungal therapy, or perhaps to manage potential complications more closely.
And how long is the typical course of treatment?
The duration specified in the notes is 14 to 21 days. And crucially, for patients with AIDS, the notes emphasize that antiretroviral therapy, or ART, is advised alongside the antifungal treatment.
Right. Why the RT specifically? Is that just to help clear the infection faster?
It's actually primarily to prevent recurrence. Remember, the underlying issue is the weakened immune system due to HIV.
Ah, okay.
So while antifungals treat the active infection, RT helps restore immune function over time. By improving the body's own defenses, you significantly reduce the risk of the candidiasis coming back once the antifungal course is finished. It's about addressing the root problem.
That makes total sense. Treat the infection, but also treat the reason the infection happened in the first place. So what's the typical outlook for someone treated for this? Prognosis.
The notes are generally quite positive here. They state the prognosis is generally good with appropriate antifungal treatment. Most patients see their symptoms improve relatively quickly, usually within days to maybe a few weeks of starting therapy.
Is it always straightforward, though?
Not always, and the notes include an important caveat. Severe immunosuppression can definitely impact the prognosis. The long-term outcome really depends on how well the underlying condition, the thing that caused the weakened immune system, can be managed.
So if immunity stays low.
Right. If immunity remains severely compromised, the risk of recurrence or potentially more severe disease persists.
That ties back directly to the importance of managing the underlying cause, like you said, especially in AIDS patients with ART. What about complications? What are the potential problems if it's severe or not treated effectively?
Well, while it's usually treatable, complications can occur. The notes list esophageal strictures as a potential problem. That's a narrowing of the esophagus due to inflammation and scarring.
That sounds like it would make swallowing even harder, potentially long-term.
It certainly could. A rarer but more serious complication mentioned is perforation, basically, a hole forming in the esophageal wall.
Wow.
Yeah. Another significant risk, particularly in severely immunocompromised individuals, is dissemination to other organs, so the fungus spreading throughout the body.
That sounds very serious. Systemic infection.
It is, yeah. It indicates a systemic, potentially life-threatening infection. And finally, recurrence of the infection itself is listed as a potential complication, especially if that underlying immune issue isn't properly addressed. The notes really reinforce that early diagnosis and treatment are crucial in preventing these more severe problems.
So looking back at how the notes were structured, it really does follow such a logical path, starting with the definition, then the why, the etiology, risks, pathophysiology, then the who, epidemiology, presentation, the how to figure it out, investigations, what to do about it, management, and finally the outlook and potential problems, prognosis, complications.
Yeah, and what's interesting is how this structured approach, the one presented in the notes, is actually such an effective way to organize medical information for learning, isn't
It
it?
really seems like it.
Breaking down a condition into these distinct sort of bite-sized sections, cause, risk, symptoms, diagnosis, treatment, it just makes it so much easier to understand the complete picture and, importantly, to recall the key facts under pressure. It really aligns with getting that high-yield knowledge you talked about earlier.
It feels like you've just built a really solid foundation of understanding by walking through it point by point like that. Very clear.
And that was the goal, really, to translate those structured notes into a clear conversational deep dive, pulling out everything you need to know.
So just to recap, we've taken this deep dive into esophageal candidiasis, starting with that fundamental definition. Fungal overgrowth, strongly linked to a weakened immune system, primarily Candida albicans.
We explored the wide range of risk factors, from the big ones like HIV/AIDS and chemotherapy to, well, a surprisingly diverse list, including diabetes, poor oral hygiene, even pregnancy, highlighting how various factors can compromise the body's defenses against this common fungus.
We walk through how the infection actually invades the esophageal lining, causing those characteristic plaques. We understood the differential diagnoses, things like GORD and other viral esophagitis. And we saw how it presents clinically, mainly with pain and difficulty swallowing, noting its significance as an AIDS-defining illness.
And we covered the diagnostic steps, from the definitive endoscopy and biopsy to that practical therapeutic trial with fluconazole. We detailed the management with antifungals, like fluconazole first line, and stressed the critical role of ART in AIDS patients to prevent recurrence.
Finally, we touched on the generally good prognosis with treatment, but also warned about potential serious complications like strictures or dissemination, especially when immunity is severely compromised.
It truly is a condition where understanding that interplay between the organism, Candida, and the host's immune status is absolutely paramount.
As we finish up this deep dive, here's a final thought for you, the listener, to consider, drawing from these notes. Given that increasing global prevalence of non-albicans Candida species, some of which, as we mentioned, are resistant to fluconazole, like Candida auris, how might this changing landscape influence how we initially approach a patient with suspected esophageal candidiasis? particularly, in terms of deciding whether to pursue early species identification versus relying solely on a therapeutic trial.
It's a really important question, isn't it? It highlights how epidemiology can directly impact clinical decision-making right there in practice.
If you found this structured approach to breaking down medical conditions helpful for your revision, remember you can find additional resources similarly designed for learners over at passthemsra.com and freemsra.com.
Yeah, they offer more materials structured to help you gain knowledge quickly and thoroughly, just like we aim for today.
A big thank you for letting us deep dive into these notes with you today. We hope this has been a really valuable session for your learning.
Helping you get that essential high-yield information from your sources. That's what the deep dive is all about.
Until the next deep dive.